afternoon, everybody. Welcome to the most interesting session of the conference, which is the complication session, which is really well attended, even at the end of the day. We all learn from our complication, and we share our experience together. So I'll start with the co-chair with me, co-moderator, Dr. Fawaz Al-Mtairi, and I have the panelists with me, Dr. Mohammed Al-Atabi, Dr. Zakaria, Dr. Al-Jabari, and
Professor Al-Goufi.
Professor Al-Goufi.
Actually, we select the most senior and people that interested to teach us how to deal with the complication from imager and senior interventional cardiology.
Very good. So we'll start with the first speaker because of sake of time, and he's tied up with his flight. Dr. Khalid Saidi from the National Heart Center in Oman. He's going to present a very late sinus sequestration case.
Assalamu alaikum. So I'm going to present this case, a 73-year-old female with a past medical history of diabetes, hypertension, dyslipidemia, asthma, osteoporosis, limited mobility at home. She had history of severe AS and underwent transfemoral TAVI with 29 millimeter evolute FX. That was done 1 year ago. She had angio prior to TAVI that showed borderline middle AD stenosis, which was treated conservatively. Now the patient presented almost a year later with worsening chest pain and shortness of breath of 2 weeks duration. This is the ECG, and as you can see, this ECG is clearly showing evidence of global ischemia with ST elevation in AVR and maybe V1 with ST depression in almost 9 other leads. So this is a clear picture of left main or left main equivalent. This is the lab investigations. In general, everything looks okay except troponin, which was high and rising, but otherwise renal function is okay. Even lactate is normal, CBC is fine, inflammatory markers are okay. This is her echocardiogram. Now this patient, a year ago, not a year ago, actually a few months ago, she had follow-up and her LV function was normal with no regional wall motion abnormalities. So what you see now, this reduced LV function, if about 40-45%, with new regional wall motion abnormalities, it just happened. The valve looks okay, no stenosis, no BVL. So the only issue is new reduction of LV function. She went for a diagnostic angiogram, and basically this is the picture we are seeing. So you see the coronary is technically same, unchanged from last year, but there is no much blood reaching there because of this narrow opening at the ST junction. So the blood supply from the aorta to the sinuses is actually impaired. And you see some floating clots in front of the ST gate junction. This is a picture of the LAD. As you can see, there is middle AD lesion, which is unchanged from last year, and of course also some spasm because the patient was on some pressors at this time. And this is the RCA. Again, the RCA is difficult to engage, also so again non-selective pictures, but looks small, but no stenosis. So here the problem. We have sequestration of the sinus of Valsalva, and this happened very late. It can happen immediate, of course, and people familiar with that, but when it happens this late, it's like unexpected. You see down in the sinus, you see the leaflet, so the white thing down is the leaflet, but on top of that you see something also filling defect, which look like clots. So we went back to look at her TAVI procedure, and this is the post-TAVI aortography. And as you can see, at that time, the flow was okay to the coronaries. You see the valve is implanted high. Probably we are trying to avoid a pacemaker, and we are following the latest trend, which is high implant. So this is high implant, big valve, and the sinuses are narrow. But at that time it was okay. We didn't have major issues. This is the measurements by CT before TAVI. And as you can see, the sinuses are relatively small. The mean diameter of sinus is 28. The valve is 29, appropriately sized according to the annulus size. But the sinus is relatively small. The coronary height is okay. It's not low. Coronary height is fine, but sinuses are relatively small. And of course, probably this was okay when the patient was, it was okay when initially, but later on something else happened. So this coronary CTA was done after that, and it clearly showed evidence of hypoattenuating leaflet thickening, about 2 millimeter. So this is thrombus, basically, valve thrombosis. Happening at this time, and this probably worsened the situation. This is why you are getting from maybe partial sequestration or impending sequestration to full-blown sequestration of the sinuses. So the management, initially we thought this is, there is halt, valve thrombosis, we need to anticoagulate, and maybe we'll consider stenting later on because of the concern of thrombosis of the stent itself. So that was the thinking at the time. And the patient, of course, was too old and frail to undergo surgery. Unfortunately, this patient didn't have a good outcome, so she continued to have chest pain, and despite anticoagulation and DAB, anti-angiogenic medication, and so on. And 1 week after her admission, she developed severe hypotension and died from what we think is combined septic and cardiogenic shock with multi-organ failure. So we did right heart cath at the time, and that showed actually low wedge pressure. So her pressures were low, wedge pressure was low, but the cardiac index was also low. So we think this is cardiogenic plus maybe some distributive shock or septic shock, something like that. And this is literature review. So we have this case series in this article. They explain the same thing. Here you see the narrow area at the ST gate junction, and this is what they did. They went with balloon, 5-0 balloon, over basically a Grand Slam, a wire, supportive wire. They don't have to get into the coronary, you just get into the sinuses, and you just open this area, and then this is how they place the stent. This is a Herculean stent from, peripheral stent from Abbott. It's deployed, and you get this area to open and supply the coronaries. So learning lessons from this case, appropriate selection of TAVI platform and sizing are essential to avoid sinus of self-sequestration, and the same thing about the technique of implantation. So maybe retrospectively speaking, maybe we would have a better chance with this patient if the valve was implanted a little bit deeper rather than a high implant to avoid pacemaker. Sequestration of the sinuses can happen late, and in this case actually very late, and it should be recognized. And interventional management is feasible. Of course, here we're concerned about the thrombus and so on, but I think that would have been the way to go, is to stent this area. Thank you very much.
Thank you, Khalid, for the presentation. We'll leave it now for comments and.
So just great case, sort of for your loss. The problem I think with the sizing was the average. Average for the sciences is very nice and is applicable in most of the cases, but here it was driven for the non-coronary sinus, which is the least important sinus. We think that the valve can center itself between the sinuses, and it doesn't happen most of the time because your calcification in that valve was in the left coronary leaflet and the right coronary leaflet. So it wouldn't really be centered, and most likely the valve would be pushed toward the left or the right and cause the problem.
Yeah, I totally agree with that.
Any comment? Anything?
Thank you for sharing this case. So many of us, they don't show their failures, but it takes a courage to show this case for teaching purposes. This is a brilliant case, and it's, as you said, it's a late sequestration of stage E. And the way to see it is either to prevent it, and probably with a longer frame, the best way to prevent it, which was mentioned partially by Dr. Ahmed, but the way to prevent it is probably to try to measure the stage E diameter and correlate it to the average mean diameter of the annulus, to ensure that there will be a stage E to the frame is more than 4 at least. So this is one way of predicting it. The second point, if you are in doubt at the first valve implantation of that figure, it's not safe, go down. Go down to leave a room for you in the future, just to minimize the chance of late sequestration. The treatment, as you said, is the moment you see it and you see band ischemia represented by the ECG, all leads are negative except AVR, which looks at the right side of the heart, and V1. The whole myocardium is ischemic, so at that point there is no, you just don't wait, just try to go there and squeeze that thrombus and protrude the stent, as you mentioned in the literature. This is a good, and thanks for sharing this experience.
Thank you very much.
Great. Thank you very much, Khalid. It's a great
I just
case.
want to allow me, great comment from Dr. Mohammed and a great case, but I think we do not do enough of a job for our screening. If you put the valve in the 3NCU and you really scroll up and down, you will figure out most of the time, but we don't do it. Even myself, at least I'm looking at a tube, then I will go back and look at it. But the majority of cases, you assume the sinus is big, but I think the tools is there. When you simulate the valve, it can tell you exactly at the STD how many is it, more or less than 2 millimeter. Great case. This is something I haven't seen before, so thanks for sharing it.
So the message here is the most important way to treat sequestration is try to prevent it from the beginning by appropriate sizing and study the case very well. So with this, we'll move on to the next presenter. Thank you very much, Dr. Khalid.
Thank you.